Good morning and welcome to the Quality Assurance A training. This training is an introduction to the 42 CFR Part 438 Quality Improvement Requirements. At this time, I'd like to go ahead and turn it over to our presenter, Mr. Rob Libby, and he will present today on the Quality Assurance A training. Thank you.
Good morning. Welcome to the training. First slide, please. Good. So we're going to be talking today about the Drug Medi-Cal Organized Delivery System Quality Assurance Requirements. So this is all sort of new stuff for us. It's important information to have in order to proceed under the ODS, and that's what I'll be referring to the Organized Delivery System pretty much as the ODS, rather than go through DMC-ODS and all that. This morning, as we're talking about this, there are a number of requirements. None of them are overwhelming, but they are things that we need to know a little bit about and understand. This is phase A of the training. There are 3 phases to the training, and I would recommend that as we move forward that you're able to participate in phase B and C as well. This is sort of very much the introduction to the 42 CFR quality improvement requirements. It's very introductory information. The other 2 get into it a little bit more in depth as to what needs to be in the QI committee, the organization of the QI committee, and the QI committee plan itself. By the way, as we move forward in the presentation this morning, I'll be asking for questions, or just reminding you that you can ask questions at any time, and then we'll take some time at some point to go through them and respond to them. Next slide. So the learning objectives are to identify key terminology related to quality assurance as used in the Department of Healthcare Services, special terms and conditions. And special terms and conditions are very important. We're going to be talking about that quite a bit this morning. Understand and describe the relationship between all of the organizations that have brought about DMC and ODS. The quality assurance requirements come down from the feds to the local level, so it's really important that we understand the requirements and the special terms and conditions in particular. Also, that we can identify required components of a quality assurance plan as a component of the county's overall DMC-ODS implementation plan. Next slide. So, how did we get here? How did all this happen? How did we get to the ODS waiver? It starts on the federal level, and it's part of in writing in the federal level as part of the Social Security Act. Which states that they intend to ensure that a continuum of care is available to individuals with substance use disorders. And I wanted to focus for a minute on continuum of care. That's really important in what the ODS is trying to achieve, that we're moving away from sort of a program as a definition of treatment and moving to a continuum of care. We'll be talking more about that. On a federal level, the ODS is implemented by CMS. CMS is the Centers for Medicare and Medicaid Services, and that's the agency at the federal level that the state has contracted with in order to implement the ODS in the state of California. Next slide. So the California did apply for and received approval from CMS to participate in the ODS according to a set of conditions. Again, we see the special terms and conditions. When the state applied to the feds for the ODS, they did so saying that they would implement the special terms and conditions. And so that gets passed on down to the counties as a requirement for county participation. Counties submit implementation plans to DHCS, as many of your counties no doubt have, for approval, which then become the requirements for local programs to become part of the county organized delivery system. Next slide. So this just kind of, again, summarizes the sort of levels of responsibility and how the ODS progresses from the federal to the local level. 43 CFR is where it begins. It sets the requirements for the California special terms and conditions, which become the county's special terms and conditions. And the counties will pass on to providers at their level, essentially the same special terms and conditions. Next slide. So one of the things that's really important about the ODS in terms of it being different from the way that we've operated in the past is that it is a managed care, excuse me, a managed care system rather than fee-for-service. In the past, what most of us have been used to on a county level, when we contract for services with providers are used to when they contract with the counties, and what counties have been used to in dealing with the state, is basically a fee-for-service system. So when you provide a service, you're paid for that service. If you don't provide the service, you don't get paid. So you have a rate, for example, maybe of $150 a day, $190 a day, whatever, for a residential day, for example. If somebody is in that bed for a residential day, the licensing requirements are filled, you get paid for that. If there's nobody in the bed, you don't get paid. That's basically a fee for service. What happens with the managed care system is that, I guess we need to go probably next slide, is under a managed care system, the counties are working with a set amount. You negotiate the counties negotiate with the state for a specific amount of money to pay for services in the continuum of care for all the ODS services. And they've got to be able to do that, or if their costs, if your local costs exceed what you've negotiated with the state in a managed care system, you have to cover those costs. The county has to cover those costs somehow. If you are able to provide those services for less than the negotiated amount, this is the good side of it, you can keep the remaining funds. If local costs are less than the prepaid amount, then the county can use the remaining funds. Okay? Therefore, both the funders, the feds and the state and the county ODS are concerned with utilization management and quality assurance. Why is that? If you're able to somehow come in under the amount that you've negotiated with, as it says here, then you get to keep that money, right? So one of the things that the feds and state are concerned with is that the patient is getting the right level of care and they're getting the right standards of quality care while they're in treatment. One of the ways that a county or providers might try to reduce their costs would be to maybe provide lesser services, keep people in a level of care and step them down to a less expensive level of care more quickly, to find ways to cut back on the costs. And so they are looking at that, both the feds and the state and the county will be looking at that with providers to be sure that utilization follows the correct standards and the quality of care is given. All right. The best way to understand this difference between fee-for-service, I think, and managed care system is if you're familiar with the way insurance companies work. Wherever you work, or maybe you worked in the past, you might have a choice between a PPO insurance plan, which is kind of more like fee-for-service, or an HMO. An HMO is a managed care system. So Kaiser, for example, is an HMO. And so within a managed care system, your care as a patient gets managed by the company. So if you're a Kaiser patient, you may go to a primary care physician, and they sort of decide, you know, what specialist you're going to go to, what kind of lab work you might need. They sort of direct your and control your care. In a fee-for-service system, it's a little bit more open, and so you have a lot more choices. And so it gives you somewhat of an idea about how we're working, and this is more like the sort of Kaiser system, if you will, as a program, as a company, as a county, or as a provider. You sort of take control, and we'll talk a little bit about how those controls work, of the patients that is within your system. And you see that they're moved between levels of care and what services they're getting as a way of being sure that they get what they need, but at the same time that you're controlling costs. So I hope that kind of helps as a example of how managed care works. Next slide. So public accountability. As we've talked about, this ODS comes from the feds. They provide the money for this. This is Medi-Cal. Comes down through the state to us, and we've all got to be accountable for that money. So how does that work? Do the feds care? Do the state care how your programs are modeled? You know, do we need to use a social model, a medical model, harm reduction model, abstinence-based model? Are there any issues there at all? The answer to that is in the second bullet, that CMS, that federal department, and DHCS pay for any professionally recognized approach at the service delivery level, as long as there's accountability for appropriate utilization. So that we'll talk a little bit more about this, that there's medical necessity established for whatever level of care somebody is in, so there's appropriate utilization, that there is quality of care, that there's good care, that the care that people are getting is up to standards, and that's what quality assurance is all about. And then they'll be looking at outcome effectiveness as well, and we'll be talking a little bit more about that. If I had to sort of throw in my own kind of comment on this slide, which I'm probably not supposed to do, but just my own opinion would be that as outcome effectiveness is evaluated, and UCLA is going to be doing some outcome studies on the work that's being done under the ODS program work that's being done, that some of the models will probably begin to look a little bit more effective than others. And if that happens, or when that happens, then I think there might be more of an interest on the basis from CMS and DHCS as to what program models are better. But at this point, there's no choice in that, as long as there's accountability for utilization, quality, and good outcomes. Next slide. So this is sort of again, a summary kind of slide about what we've talked about. The chain of accountability, again, starts with the feds at Health and Human Services. They oversee CMS, that's their federal agency, which oversees Department of Healthcare Services in California, which oversees counties. This is how it all gets sort of passed down. That oversee provider organizations, that oversee staff practices. So this is the chain of accountability, and everybody along the line there is accountable. Next slide. So what HHS has done is they have set out their goals, and this again gets back to quality assurance. Their goals are better care. Seems like an obvious one, but This is the basis for setting quality standards and using QA to monitor their achievement. If you're going to have better care, you have to have quality care. Healthier people, healthier communities, which is the basis for outcome studies in order to establish that with some accountability there, the people are really healthier, communities are healthier. They've got to do outcome studies to show that there is improvement in people's health, and that it's affordable care, which is the basis for utilization management within Q of A, that we're tracking the cost of care as well, and that we are providing care at a level that the patient needs, but no more than the patient needs, so that it's affordable care. Next slide. So now we get into acronyms and terminology, something that most people are not too fond of probably, but I think, you know, it's important to understand that as we move into the ODS, we're moving into a somewhat different world in terms of the language that we'll be using to describe various parts of the treatment world. For the last 20 or 30 years, the treatment world has been pretty much the same in the way that it's funded and the way programs are described and standards, etc. Under ODS, it changes a little bit. So it's a good idea to get familiar at least with the terminology that we'll be using and the acronyms as well. So we'll run through this. There's 4 or 5 slides on this. We're not going to spend a lot of time, but I think it's worth taking a look at them. QA, quality assurance, and QI is quality improvement. As the third bullet says, QA and QI are used interchangeably in DMC-ODS documents. So as you read various documents that come out, letters that come out on ODS, you may find that those are used interchangeably. Don't get upset by that, because I know that many of you are probably looking at that thinking QA and QI are not really the same. Quality assurance and quality improvement can be two very different things, but they are used in ODS documents to mean essentially the same thing. They're sort of interchangeable. Next slide. HHS stands for Federal Department of Health and Human Services. CMS, again, we've talked about that, stands for the Centers for Medicaid, and I think it should be Medi-Cal and Medicaid Services. The division of HHS, that's the agency at the federal level that kind of runs the Medi-Cal work. And that, of course, is passed down to DHCS, which is Department of Healthcare Services, which I'm sure you already know what that stands for. Next slide. CFR is a Code of Federal Regulations. We'll talk about Code of Federal Regulations here because 438 in the Code of Federal Regulations is what lays out ODS and describes ODS. You are familiar with CFR in the past, if for no other reason than 42 CFRs, of course, where confidentiality rules are, and that's always been a big thing in the field to understand that. Let's see. So CFR, or I'm sorry, the state plan is the state's federally approved written plan for implementing CFR requirements through the state's various counties. So wherever you see state plan in these documents, that will be the approved plan that the state of California has with the feds. STCs, special terms and conditions, those are in the state plan. They must be addressed in the county plan as well. So in the county plans that you wrote for implementation with the state, those were based on the same special terms and conditions that the state has in their contract with the Fed. So again, all of this, one of the reasons that quality assurance, the way that it's implemented in programs, local programs, and at the county level, is that these sort of promises under the special terms and conditions come all the way down from the Fed. So at each level, like the county is answerable to the state is answerable to the feds, and they've all said, we are going to work within these special terms and conditions, and so they need to do that. Next slide. IP, when you see that in documents, is the implementation plan. It refers to the county's overall implementation plan for meeting the terms of the DHCS STC. So that's the plan that the county has approved with the state. That's your implementation plan. Prepaid inpatient hospital plan is something that we probably don't want to focus on too much because it's not going to show up much in the documents that you see. Prepaid inpatient hospital plan is a managed care, is a type of managed care plan, and it's the type of managed care plan that is in the agreement between the state and the feds. But it's not really a concern probably to most of you. The interdepartmental agreement or the interagency agreement or the intergovernmental agreement is the managed care contract. It's the contract between the state and county based on the state's acceptance of the county's implementation plan. So the county has sent in its implementation plan, its proposal, if you will, and the agreement that comes out of that is the IA. And then the contract is another word for the IA. Some of these are a little bit duplicative. That's why I don't want to get us too, well, it's a good thing to know generally what these terms are. We don't want to get too focused on their individual definitions. Next slide, please. So the QIP, the Quality Implementation Plan, that's the QA focused portion of the county's implementation plan. So within the county's implementation plan is where the quality assurance document is. Right? And that's the QIP, that's within the implementation plan. Performance Improvement Plan is very similar to the QIP. And it's used synonymously with the Quality Improvement Plan. And there's a couple of different PIPs here. There's a Performance Improvement Plan and a Performance Improvement Project, and they're a little bit different. So when you see the PIP, you need to be sure of which one of these two they're defining. The Performance Improvement Project is a term for a corrective action plan based on a QA review finding. So when the agency, which we'll talk about a little bit later, the EQRO agency comes in and reviews you, and if they find some things that need to be done as performance improvement projects, that's the term for the corrective action plan. The next one, the CAP, or the corrective action plan, is really the same as a performance improvement plan. And this has been used for years in DHCS documents, as you're probably very aware. When the state has come in just to do licensing reviews, or if they come in to do Medi-Cal reviews and they find that your programs are wanting in some fashion, that there's something that you're not doing or not doing well, they will ask you to explain how you're going to do that better in the future, and that's always been the corrective action plan, and that remains pretty much the same, the CAP. EQRO, this is a sort of a new acronym, a new term. For us, the EQRO is the External Quality Review Organization. It's an entity that's going to work statewide to review quality assurance and quality service performed in county programs. And they will issue the performance improvement projects and the CAPs where the deficiencies are found. So every 12 months, your programs will be reviewed by this external agency to determine how well you're doing in terms of your quality assurance. Next slide. MCO is a managed care organization, basically the county department that applied for and is implementing the IP, the implementation plan. The MCP, or managed care plan, is not a plan document, but a term that refers to the managed care organization. And then finally, the ITP is the individual treatment plan, or the individualized client plan, and this is something that you have dealt with for years. These are basically this defines a treatment plan, although it's now called individualized treatment plan or individual treatment plan. So there is an emphasis on that, on the individual, and it's a plan for the client's services, their goals, objectives, and planned interventions. Next slide. DMC-ODS, I think by now we all know what that is. MHP, the mental health plan, the county entity's responsibility for implementing Medi-Cal mental health. I think you're familiar with that as well. Next slide. This is going to get a little bit confusing, so we're going to spend very little time on it because I don't want to make it any more confusing than it needs to be. Well, in the documents, you'll see plans used in two different ways. And one way they'll be used to define written documents. So when they talk about the state plan, which is the state's written agreement with the feds, basically, or a county's DMC-ODS implementation plan, that's a written document. County's quality improvement plan, which would be within the implementation plan, that also is a written document. These terms can also refer to organizations. So a state plan can be the state. A managed care plan could be the county. And then as breaking it down further, it may refer to an individual county's plan. So it can when the term plan may be both a written or a definition of a written plan or an organization. I want to remind you that we can have questions at any time. So if you have questions, be sure to type them in. We did get one question at this point asking me to clarify how often the EQRO review would be. What is stated is that they will happen every 12 months. They'll happen once a year. And there is a oh boy, there's a document that's on the DHCS website. If you go to the DHCS website and you put in EQRO, you'll find a number of documents come up. One of them is a presentation that was done, I think it was last month, on the EQROs and how that's going to work. And I would advise that you might want to take a look at that. Plans are being implemented at different times of the fiscal year, so exactly when their first review would be, I think, is stated in that document. It's all a little bit different depending on when you actually implement the plan. But once it gets going, the standard is that the external review will be once a year. Next slide, please. So this is an exercise you don't have to do. You'd be happy not to do this. This slide is in here for the in-person presentations of this particular presentation, but it's something that you might want to do in your spare time. And the exercise would be to write a paragraph using these acronyms that explains the relationship among these various plans. And when I've had these done in our other presentations, they usually turn out to be useful and also a lot of fun to do. Next slide, please. We won't do those. But the reason for that exercise is to make sure that people are familiar and have some, they are able to use those terms in a way that makes sense. Let's see, where are we? Okay, what must be addressed in a county's quality improvement plan? Next slide. Now we're getting into the real requirements. DMC organized delivery systems of Medi-Cal benefit in counties that choose to opt into and implement the pilot program. Any county that elects to opt into DMC-ODS services will submit an implementation plan to the state for approval by DHCS and CMS pursuant to Attachment Z. Now there is a document that will be put on the CIBHS website, and they may talk about this when this presentation is done. As to when it will be put on there, but there is a really important and useful document that's called Quality Assurance in a Drug Medi-Cal Organized Delivery System, and it has specifically what the requirements are, what the QIP, we'll be going through those in this presentation, but it sort of spells it out for you, and it's a very useful document to be looking at when you're putting your quality assurance committee together. It can be a very helpful document to have to work with, because it is very specifically bullet points of everything that needs to be in that plan. Had another question, I think, that is more of a statement than a question. The duplication of words and acronyms is a recipe for problems. Why are they doing this? I can't answer that question. I think probably that things like performance improvement plans that the PIPs are simply duplicated, and they're fairly close in definition. But I agree that it's a little bit problematic. Okay, next slide, please. Attachment Z. Attachment Z is the document I just referred to. Attachment Z is the part of the requirements by DHCS that has the special terms and conditions that are going to define for you what needs to be in your quality plan. Okay, so it has all of those within. That's why it's an important document, and that's why I hope you get a chance to take a look at that. Next slide, please. Let's see. So in part, well, without having attachment Z right in front of you, it's, this probably isn't quite as important, but part one of attachment Z is the document that describes not so much what's in the quality section of it, but what is in the implementation plan overall that the county has written to the state. And in part two, the county describes how those commitments will be fulfilled. Next slide, please. Okay, so QIP requirements, quality improvement requirements. So each county's quality improvement committee will review the following data at a minimum on a quarterly basis, since ERQ site reviews will begin after county implementation. EQR, I'm sorry. These data elements will be incorporated into the EQRO protocol. Number of days between referral assessment and first DMC-ODS service follow-up appointment. So these are the things that are going to be looked at. These are the things that you're going to have to be keeping some data on. You're going to have to be living within certain rules, because between the first assessment and the first DMC-ODS service follow-up appointment, their first treatment appointment is supposed to be 7 days. You're going to have to be able to track those times so that you can show that you're living within that, right? That's part of that utilization management that we talked about before. A 24/7 telephone access line with prevalent non-English languages, so whatever the prevalent non-English languages are in your county, you have to have a 24/7 telephone access line operative. Access to translation services in the prevalent non-English language, and data on approved or denied authorization requests. So you're going to have to be able to show when you approve, or more importantly, maybe when you deny an authorization request, why that is, and have that data available. Next slide, please. So access to services in accordance with 42 CFR 438-206 describe how the county will assure the following. By the way, if you Google 42 CFR 438 and you want to take a look at it, that's the portion of the federal law that describes the organized delivery system and what the standard terms and conditions are. Essentially, that's the basis of it. And while most of us are not probably fond of reading federal government documents and reading small print, that sort of thing, this one reads pretty well. It's pretty straightforward, and if you're in an area of your work where compliance and quality assurance and utilization management and tracking, data on these items is important, I'd recommend taking a look at it. It's not really exciting reading, but it's not as bad as a lot of the federal regulations are. So they describe it that the county will assure the following: meet and require providers to meet standards for timely access to care and services, taking into account the urgency of need for services. So you've got to be able to show that you're meeting standards for timely access to care. They require subcontracted providers the counties are requiring subcontracted providers to have hours of operation during which services are provided to Medi-Cal beneficiaries that are no less than the hours of operation during which the provider offers services to non-Medi-Cal patients. And so there has to be equality in the treatment of Medi-Cal beneficiaries. If you do weekend admissions for your insurance clients, then you do weekend admissions for your Medi-Cal beneficiaries. It has to be equal access to services. If there is a waiting list, there is a waiting list for everybody, right? Make services available to beneficiaries 24 hours a day, 7 days a week when medically necessary. So somehow within your system, and this is going to be very, very hard to do. So the medically necessary is important. If somebody needs services immediately in the middle of the night on Saturday night, the medical necessity would probably mean that they require ED or hospital work. Next slide, please. So access to services, continue to establish mechanisms to ensure that the network providers comply with timely access requirements. So I'm not quite sure what they mean by mechanisms, but all of the providers within the county or within the network all have to, of course, apply to, all have to have timely access and comply with those requirements. Monitor network providers regularly to determine compliance with timely access requirements. So there has to be something in the quality plan that says that this will be done on a regular basis, right? Which makes a lot of sense. I mean, if you're going to be looking to see that people have timely access, it's got to be something that is done on a regular basis, not done once in a while, and that you only look at it once a year to find out maybe that it's not being done right. So you want to be able to monitor the network on a regular basis. Take corrective action if there's a failure to comply with timely access requirements. So there has to be a CAP, if you will, corrective action plan, if you find that the providers are not meeting timely access requirements. Timely access is a big deal within the ODS. I mean, it's not new to us in the field, but under the ODS, it's something that's going to be looked at very carefully, so that people do not have to wait a long time to get in. Okay, so I have a question here that has to do with waiting lists, something I probably shouldn't have mentioned. It says, you mentioned if there's a waiting list, then a waiting list for everybody, but doesn't DMC-ODS require that there are no waiting lists? That is technically correct. And I'm probably getting on a little bit of thin ice when I talk about waiting lists. But within certain networks, it's going to be something that is pretty hard to avoid. If you have a network within a small, medium-sized county, and you have 25 residential beds, for example, and you have someone who qualifies on an ASAM level for residential care, that's what they need, and they either can't or won't do intensive outpatient or any other level of care while they're waiting for a residential bed, for example. I don't know what you want to call it, but there may just not be a way to fulfill that person's need. So while there technically can't be a waiting list, there's going to be situations, I think, that are very close to what we have always had, where there simply is not the capacity on every level of care. I think you find with intensive outpatient, for example, that's a program that's easy to grow. You know, if you have enough people to start another group, which is not very many people, then you start another group. But when you get into residential care, it's a little bit different. The flexibility the ability to expand is a much more expensive and much slower process. So the idea that there's going to be a more fluidity than there's been in the past in terms of moving people into residential care, I'm not quite sure how that can work. Next slide, please. So then there is a part 2 also in attachment Z that has the QIP requirements, and specifically of quality assurance. It says, describe the county's quality management and quality improvement programs. The description must include, next slide, description of the Quality Improvement Committee or the integration of DMC-ODS responsibilities into the existing mental health plan QI committee. So what they're saying here is that under the substance use disorder program, there has to be a quality improvement committee on that county level and recommended on a program level as well. But you can also integrate the DMC-ODS responsibilities into the existing mental health QI committee. So there are counties they're saying you can do it either way. What most counties are doing, I shouldn't say that most counties are doing this. The counties that I'm familiar with, most of them are integrating the substance use disorder, the DMC-ODS quality improvement committee with the mental health committee, simply because the mental health has been doing this for a longer period of time, and those committees already exist. And the standards already exist, and similar standards already exist, and it's easier to integrate. It takes less person power to integrate and staff those committees than it does if they're done separately. But they can be done either way. And within the composition, you describe who will be the ex officio members, which members will be chairperson, to whom does the chairperson report, how often will the QIC meet. All of those items need to be stated regarding your quality improvement committee. Next slide. Well, the other pieces that need to be included are, will the QIC establish practice standards? If so, how will they be developed? I assume they will establish practice standards. Unless you're integrating with mental health, there may be practice standards that are already there that are similar. What data sources will QIC review to determine whether or not standards have been met? So this is kind of a new item for some counties. In some programs within counties, and that is that data is going to need to be kept on, probably more data is going to need to be kept on practice standards and how those practice standards are being met than we have done in the past. So I have to determine what it is you're going to be looking at in terms of data sources to determine whether or not standards have been met. This kind of goes back to the beginning of the presentation when we were talking about the special terms and conditions. Counties have to meet those special terms and conditions. So what they're going to be looking at in terms of standards are data sources that will prove that you are meeting certain quality standards. And that's something that on the substance use disorder side has not been necessarily required in the past and hasn't been done in the past, so it's going to be kind of new work. To whom will review findings be reported? What's the sort of chain of command these go to? Who will develop corrective action plans within the committee? So all of that needs to be in the document that describes your quality improvement committee. Those all have to be within that. Next slide, please. And the Quality Improvement Committee also will address the monitoring of accessibility of services. This accessibility of services, again, keeps popping up throughout any discussion of quality and utilization management, because accessibility is something, if we go back to the beginning, that's what Health and Human Services at the federal level promised, that there'll be more accessibility. That gets passed down to the state, and the state has to then lean on counties to see that the accessibility happens. It's an important part of, very important part of the ODS. Next slide. So the monitoring of accessibility of services outline quality improvement plan will at a minimum include the timeliness of the first initial contact to face-to-face appointment. So that sort of from the time that someone calls in or makes first contact until the time they get a face-to-face appointment. So they may call into a 800 number or whatever for general number to the county for services, and from that point to the time that they get a face-to-face contact, for example, at a program, where they show up at a program for an assessment, that period of time has to be tracked. The frequency of follow-up appointments in accordance with individualized treatment plans is tracked. That's going to be tracked pretty much in charting the patient. Timeliness of services of the first dose of an NTP service, and access to after-hours care. How well you're doing in terms of people being able to access after-hours care also is something that you will track. Next slide, please. More requirements, the responsiveness of the beneficiary access line, and I don't know how this gets done in every situation. I've talked to people in counties where they have really great phone systems where things like wait times and unanswered calls, hang-ups, that sort of thing are tracked automatically, and that's kind of a nice thing if you could do that. But how responsive you are on the beneficiary access line and responding to people calling in or trying to make contact needs to be tracked. Strategies to reduce avoidable hospitalizations would be included in that as well. What strategies you're going to use to reduce avoidable hospitalizations. Coordination of physical and mental health services with waiver services at the provider level. How are you going to integrate the two at the provider level? How is that working for co-occurring disorders? Assessment of the beneficiary's experiences, including complaints, grievances, and appeals. This is something that is new to programs that haven't been Medi-Cal eligible in the past, and for such as if you're operating a residential program, so Medi-Cal has not covered residential care in the past, so this is not really applied. So the state grievance process hasn't really applied in law to those programs that are not Medi-Cal covered. Programs that are Medi-Cal covered have for years followed a process where someone makes a complaint locally to the program, and they have ultimately the right to a fair hearing. That's under Medi-Cal. If you're denied access to a program, or if you're removed from a program, you have the right to a fair hearing. So the complaint, grievance, and appeals process, how that works at the county level, program county to the state level, is much more important than it's been in the past in terms of it being detailed out in your quality documents. And I think that comes up a little bit again later. But grievances take on a whole new sort of, complaints and grievances, a whole new sort of meaning under Medi-Cal. Those of you who have run Medi-Cal programs in the past know that. Telephone access line and services in the prevalent non-English languages, that you're providing that when people are calling in the prevalent non-English languages, that they're getting through and getting services. Next slide, please. Also in that document, in the QIC, it will address how beneficiary complaints data shall be collected, how beneficiary complaints data shall be collected, categorized, and assessed for monitoring grievances and appeals. So you need to be able to show how that has been tracked, how you collect them, how you categorize them, how you assess them, what their outcomes are on your grievance and appeals process. Next slide. And finally, that each county on the grievance and appeal side, that each county shall have an internal grievance process. This is what I was talking about a moment before, that allows the beneficiary or provider on behalf of the beneficiary to challenge a denial of coverage of services or denial of payment for services by participating county. The Department of Healthcare Services will provide beneficiaries access to a state peer hearing process, but that has to be outlined in a way by the quality committee, and it has to be shown to the patients, given to the patients as well, so that they know what their rights are under that process. Next slide, please. Okay, so we're getting towards just doing a time check here. This is the examples of the QA committee description. See handouts for examples of QA committee descriptions. So this information, and we're not going to be able to go into these exercises and do these exercises, obviously, and they're good exercises, but you're going to have to be able to look at the attachment Z, and that's the document that's going to be on the website of the CIBHS, the one I was talking about before. And in it, there are some excerpts from these various counties, like Los Angeles County, Marin County, Riverside County, as to how they wrote their QI committee descriptions. And they want you to sort of look at the different committees and look at how they approach quality work. And I can tell you, I can give you a little bit of a hint before you look at that, is that LA County is very complex because it's a huge county, and there are lots of different regions and programs within the county. But maybe the difference between Marin and Riverside would be that some of the quality committee descriptions simply kind of parrot what the requirements are. You know, it says in the requirements for your QI committee, you have to have this, and they say, we have this. Marin County will do, you know, will track timeliness of access to care, whatever, and that's pretty much what it says. Whereas another county may go into a lot more detail as to exactly how they're going to do that. So it's really a matter of the detail. These are all approved plans. There's nothing wrong with any of them. But if you haven't written that yet, or if you need to amend your description of how your committee is going to do QI, it might be good to take a look at that. And I think you'll find the ones that are more detailed are a little bit better, because they really put in there all the detail that the quality committee needs to know and to follow. Okay. So a question came up. Please describe strategies to avoid hospitalizations in more detail. What is DHCS looking for? So they ask in the quality committee description that you talk about strategies that you have to avoid unnecessary. I think it said unnecessary hospitalizations in more detail, or maybe it's avoided hospitalizations. At any rate, you're looking for strategies like when you have patients that are in care, might be in residential care, that have medical complaints, is there a way to channel those patients into medical care, and urgent care, for example? Maybe you have nursing in your program, or nurse hotline information in your program, anything that might correctly need, not shortchange the patient, but will get the patient the care that they need that would avoid a hospitalization, right? So that they can go and see a physician. They might need prescribed medication. They might need some sort of treatment short of hospitalization. So anything that, if you look at the kinds of things that your patients in various levels of care, so we're really talking about OTP programs, residential programs, outpatient programs, whatever it is that people have been looking for in the past that has resulted in hospitalization, what are some ways, short of hospitalization, we can still get the medical care, but do it in a way through primary care, through urgent care, through 24-hour care, somewhere other than something that will result in hospitalization. So I think that there's an endless number of strategies probably, but I think what you want to look at are what are the things that we face, the kinds of things that we're not so good at managing and do result in hospitalizations. How can those be handled differently within the system, within our quality standards, that will get the patient what they need and avoid the expensive hospitalizations? Okay. Next slide, please. So this is another similar kind of exercise on evidence that we're not going to do, because we really can't do this on a presentation of this sort. But the practice would be how will the counties ensure that providers are implementing at least two of the identified evidence-based practices? What action will the county take if the provider is found to be in non-compliance? Next slide, please. So they ask you in that document, in that attachment Z document that you're going to be able to see shortly on the CABH website, if you look at the way LA and Marin and Riverside have done theirs, they've all stated how they're going to determine whether or not evidence-based practices are done in a way that is to fidelity and done correctly. The counties are all different. Riverside counties, I'm pretty sure, I'm correct in my memory here, the Riverside counties is really written out in detail. They talk about how what each program's evidence-based practices are going to be, and then how they're going to track those to fidelity. Some of the other counties just say, we're going to be doing these particular evidence-based practices, and we will be monitoring them or something, and that's kind of all the information they give. Again, it's okay, it's approved, but it doesn't give a lot of detail. I think the more detail that you put in your plans, then the more direction you're giving to the people who are having to manage those plans. And as you know, in one of the quality items that we have with ODS is that there will be two evidence-based practices in every program. So, and they even state what the evidence-based practices are, I believe. So that's something that you do have to be thinking about, that you not only have to, if you're doing MI, then what are you doing to track the use of MI and maybe the training that your staff is getting around MI? What are you doing to show that that's being done to fidelity? Or if it's matrix or whatever the evidence-based practice is, you're going to have to be able to do a little bit of tracking on that as well. Next slide. Okay, so QI programs can be combined with or kept, we've talked about this before, kept separate from the county's mental health QI program. This is just my own personal observation, I guess, but I think that if you have a mental health QI program, integrating substance use disorder with that makes a lot of sense in terms of, if nothing else, the efficiency, if not the effectiveness, certainly the efficiency of getting the work done. And these are committees that are used to doing QI. They meet on a regular basis. They know how to review QI issues, and you can sort of integrate or blend in with them, I think, easier than establishing a separate one. QI programs can be operated at the level of a county, but can also be operated on a regional basis across participating counties if you want to do that, but it sounds very complicated to me, but you can. And then special conditions, there are special conditions for tribal and Indian health providers as well. Next slide. Okay. If you go to this this link, you can find implementation plans already, which include the quality improvement component, so that all of the counties that have approved plans, and there's a growing number of them now that are on the DHCS website. And if you go to that link, you can, if you don't have one already written yourselves, or if you're amending yours or improving your quality committee document, you can get some ideas there as to how to do it. Next slide. Okay. I don't have any fresh questions up here. I think we've answered the ones that have come in so far. If you have any other ones or recommendations for future training topics around this, you can put those in now. We'll just take a couple of minutes and see if there are any other questions.
Mr. Libby, I have been asked that someone asked that we put the link, the previous slide back up that had the link. So I'm just going to go back really quickly. Okay, thank you.
Sure, that's fine. Well, I don't see any other questions. I think we're well ahead of time, but I think we're pretty much there.
We did just have one come in, sending it right your way.
Okay.
Just came in.
So I can get this down. Yeah, this is more of a statement than a question. I'm going to read it and then respond a little bit. The comment was, one of my takeaways is that based on what I have described regarding the EQRO for DMC-ODS, it seems more punitive than the mental health EQROs. On the mental health side, there are no PIPs issued or caps from EQR review. Recommendations are issued within a larger report that outlines how the MHP met the requirements of EQO in terms of access, timeliness, and outcomes just an observation. Seems like it could be helpful to have the guidance directly from the state, but it also may mean less discretion at the county level to determine what areas of improvement to focus on. I think that I have talked with the folks that are doing the EQROs for the DMC-ODS, and their intention. I don't know. When they talk here about there will be performance improvement plans and caps, that sort of thing, they may be within that larger document. I don't know exactly how those are going to be presented. I can tell you, however, that the head of that organization has told me directly that their intention, especially in the first couple of years, is to be helpful, is to be more of a, and I don't want to put them in any light that might prove to be a problem later, but they've said that their intent is to be as helpful as they can be in terms of moving people in the right direction. So while there may be something written in the form of, you need to do a performance improvement around this, or something like a corrective action plan, talk to us about how you're going to improve this, that it's not a that it's not going to be done in a way that is that you might have gotten in terms of a cap that in the past. For example, caps in the past, when somebody comes in and does a review, whether it's a Medi-Cal review or when the state does a Medi-Cal review or a licensing review, and they do a cap, it's sort of like, you need to respond to us within 30 days to tell us exactly how you're going to fix this or else kind of thing, right? That is not their intention. That's not the EQRO's intention, especially in the first couple of years. It's going to be to point out where weaknesses may be and to ask for, but also to help with ways that they can improve that. So in just talking about PIPs and caps earlier, if I made it out to seem like it's going to be a punitive process, I don't think that's at all the intent of the EQRO. Again, especially as this begins, everybody understands that the DMC-ODS is in a sense, a pilot, and oftentimes is referred to as a pilot project. Now, a great deal has gone into the development of it, and it's going to be around for a while, but everybody understands that this is new stuff, that under the ODS, things are being asked for from programs that have never been asked for before, that in some cases there's expense attached to those, there is staff time attached to getting those things done, and it's not going to be easy to do. And we're going to have to work together to find cooperatively to find ways of getting some of those things done right. So EQRO, I think, is very much aware of that, and I do not think that it will be a punitive process. I hope that helps.
There were two other questions that came in after your last call for questions. Just to let you know.
Well, one of them, I think, one of them was just a comment and presenters thoughts that would be great if familiar with MHP EQROs. I think that I hope I hit on that. I'm not sure that they will be exactly like the MHP ones, and I'm not deeply familiar with the MHP ones, so I can't fully respond to that, but I hope I answered most of that. Let's see, where else are we going here? Okay, one of the comments that came in is that this training seemed most appropriate for county staff. Do you tailor this information when presenting to direct service providers? I've had audiences that include both county and direct service providers, as I assume this one is. because this has to do with the development of the quality assurance plan, it seems to be a little bit more directed to counties. And I think that in the very beginning, you know, we spent a lot of time talking about, or some time talking about how these special terms and conditions and all of this, all of the promises of the DMC-ODS, of the things that we're going to change, the new things, the timeliness, etc., that those come from the feds down to the state, down to the counties, and down to the providers, so that that my recommendation is that that providers work very closely with their county partners in terms of coming up with what's going to be done at the provider level. It needs to be very, very close to what's going on at the county level. The county is going to say, we need to be able to see timeliness, for example, length of time between first contact to admissions, whatever it is that they're looking for. That has to become part of the provider process. So these things are shared all the way down the ladder, from the feds all the way down to the providers. Whether or not we can do this presentation in a way that is more focused on direct service providers' needs is really up to CIBHS, I guess. I mean, I think that there's a lot of great takeaways here for providers, and the takeaway for me as a provider would be, I need to know the special terms and conditions. I want to know what the county plan, implementation plan is, what they have said to the state, and then I'm going to have to, and they're going to tell me this anyway, but I'm going to have to come up with the data that supports what the county has said they're going to achieve in terms of quality, right? So I hope that direct service providers can follow that. But if there is a need for that focused presentation for providers, I would be more than happy to do that, but it's really a CIBHS call. And that's the last one that I can see on here, unless I'm missing another question.
No, that's correct. That's the last question.
Okay.
So with that being said, thank you. Thank you to our presenter, Mr. Rod Libby, today. If there are no other questions, which I don't see any coming in, that will go ahead and conclude our presentation today. Please feel free to contact our office if you have any additional questions or any technical assistance requests, and we'll definitely address that with you. And you can find this, I will definitely send out the presentation and attachment Z to everyone following this webinar. But you can also find the recording and the attachments as well on our website by no later than probably at the end of the week or the top of next week. So that will conclude our webinar. Thank you for joining us today.